Hello, and welcome to the Medicaid and CHIP Payment and Access Commission's Medicaid 101 series. Today we'll be talking about Medicaid hospital payment and financing. But first, a little bit about macpac. macpac is a nonpartisan legislative branch agency that provides policy and data analysis and makes recommendations to Congress, the Secretary of the U.S. Department of Health and Human Services, and the states on a wide array of issues affecting Medicaid and the State Children's Health Insurance Program, or CHIP. macpac conducts policy research and analysis that is fact-driven and evidence-based. For more information, visit macpac.gov. This presentation is part of a series to provide educational content and highlight recommendations that the Commission has made previously. This presentation reviews Medicaid hospital payment and financing policies. We'll begin by reviewing the different types of Medicaid payments to hospitals, including base payments for specific services and supplemental payments, which are typically made in a lump sum for a fixed period of time. Then we'll discuss how these payments are financed. The presentation will conclude with a summary of prior macpac work on this topic and other resources. So let's begin. Overall, Medicaid spent about $245.3 billion on hospital care in 2021, according to the National Health Expenditure Accounts. This accounted for more than 1/3 of all Medicaid spending and about 19% of all payments to hospitals from all payers. Medicaid payments to hospitals can be described in two broad categories. First, there are base payments for specific inpatient or outpatient hospital services. These can be made through fee-for-service delivery systems, where the state pays a hospital directly, or they can be paid through managed care, where states make a capitated payment to health plans who then pay hospitals. The second broad category of payment are supplemental payments, which are additional lump sum payments typically made for a fixed period of time. There are many different authorities that states can use to make supplemental payments, and these payments currently account for more than half of all Medicaid payments to hospitals. This figure shows the distribution of base and supplemental payments to hospitals in fiscal year 2021. Overall, supplemental payments account for more than half of fee-for-service payments to hospitals, and managed care accounts for a little bit more than half of all Medicaid payments to hospitals. In recent years, states have begun making directed payments to providers, which, as I'll discuss further, are similar to supplemental payments in fee-for-service. So now let's look at each of these payments in more detail, starting with base payments. Overall, fee-for-service base payment rates and methods must be consistent with the statutory goals of economy, efficiency, quality, and access. In order to enforce the standard of economy, the Centers for Medicare and Medicaid Services, or CMS, has established regulatory upper limits on aggregate payments to hospitals, known as the upper payment limit. In the aggregate, payments to hospitals can be no more than a reasonable estimate of what Medicare would have paid for the same service. CMS is also responsible for reviewing and approving fee-for-service payment rates and methods, which are described in each state's Medicaid state plan. Overall, there's considerable variation in state payment rates. For example, according to macpac's analyses, in 2011, Medicaid inpatient base rates ranged from 49% to 169% of the national average by state. In general, Medicaid base rates are often below hospital costs or the Medicare payment rate, which is one of the reasons why states have chosen to make supplemental payments. In managed care, the rates paid to health plans are required to be actuarially sound, and actuaries often use fee-for-service base rates as a starting point for developing their rates. Although managed care organizations can often negotiate payment rates with providers, we have found in our review that many plans end up paying hospitals close to the fee-for-service rate. States are generally prohibited from making supplemental payments in managed care, but CMS has granted some exceptions to this rule through Section 1115 demonstrations and new directed payment authorities, which I'll discuss in a bit. So now moving on to supplemental payments, this table provides a summary of the use of various types of supplemental payments to providers, roughly ordered by when they were first used. I'll walk through each of these payments in more detail in the subsequent slides, but on this table I want to point out that there's a wide variation in the number of states that use the various different types of supplemental payments. There's also wide variation in the different types of goals that these payments are intended to address. Many supplemental payments are intended to support care for Medicaid-enrolled patients by offsetting low base payment rates. But some supplemental payments also pay for unpaid costs of care for uninsured individuals. In addition, some payments are intended to support particular types of hospitals, such as graduate medical education payments that support teaching hospitals. And in addition, other payments such as DSRIP, or Delivery System Reform Incentive Payment Programs, are intended to support quality improvement and delivery system reform goals. It's important to note that directed payments are not technically classified by CMS as a supplemental payment, but we include them on this table because many states use directed payments to offset low base payment rates, similar to supplemental payments in fee-for-service. So let's start with disproportionate share hospital payments, or DSH payments. DSH payments are statutorily required supplemental payments that are intended to offset uncompensated care for Medicaid and uninsured patients. DSH payments were first created in the 1980s when Medicaid payments were delinked from Medicare. It's important to note that Medicare also makes DSH payments to hospitals, which has the same acronym as Medicaid, but Medicare DSH payments are subject to different rules than Medicaid. States are required to make Medicaid DSH payments to hospitals that serve a high share of Medicaid and low-income patients, which are referred to as deemed DSH hospitals. Overall, in 2018, about 13% of hospitals met these criteria, and these hospitals received nearly 2/3 of DSH payments. States can also make DSH payments to other types of hospitals. Overall, about 42% of all hospitals received Medicaid DSH payments in 2018. This includes support for rural critical access hospitals, which are not eligible for Medicare DSH payments. Overall, Medicaid DSH payments to an individual hospital cannot exceed the hospital's uncompensated care costs, which is defined as the sum of Medicaid shortfall and the unpaid cost of care for uninsured individuals. Medicaid shortfall is defined as the difference between a hospital's cost of care for serving Medicaid patients and the payments that it receives for those services. State DSH payments are limited by federal allotments, which vary widely by state and are largely based on state spending in 1992. Under current law, DSH allotments are scheduled to be reduced by $8 billion, or about 57%, in fiscal year 2024, which begins in October 2023. Now let's discuss UPL supplemental payments, which are lump sum payments intended to cover the difference between fee-for-service base rates and an estimate of what Medicare would have paid for the same service. States are required to calculate what this upper payment limit is each year and demonstrate that their total fee-for-service payments are below this limit. In recent years, CMS has increased efforts to improve compliance with these UPL requirements in response to concerns raised by macpac, the Government Accountability Office, and other stakeholders. It's also important to note that the use of UPL supplemental payments overall has been declining as states move beneficiaries from fee-for-service to managed care delivery systems. States can also make Medicaid graduate medical education payments, or GME payments, to support teaching hospitals in fee-for-service and managed care. This is another case where Medicare also makes GME payments, which have the same acronym but have a different payment method. Unlike Medicare GME payments, there's no specific formula that states are required to follow for Medicaid GME payments. Some states make GME as a supplemental payment, whereas other states incorporate adjustments for teaching hospitals into their base payment rates. So because states can't make UPL supplemental payments in managed care, some states have sought Section 1115 demonstration waiver authority to preserve supplemental payments when they transition from fee-for-service to managed care. Uncompensated care pools are the first type of these supplemental payments, again authorized under Section 1115 authority. Uncompensated care pools are generally similar to DISH because they pay for uncompensated care for both Medicaid and uninsured individuals. However, the definition of uncompensated care used for some of these waivers is sometimes a bit different than DISH. The specific rules for each state's Section 1115 demonstration are described in the terms and conditions for the waiver, and they are typically approved for up to 5 years at a time, and so the terms can change at renewal. Delivery System Reform Incentive Payments, or DSRIP, are a newer type of supplemental payment authorized under Section 1115 authority. DSRIP payments are tied to the achievement of delivery system milestones and quality goals. Because DSRIP is classified as a quality improvement payment, DSRIP payments don't affect the measures of Medicaid shortfall that are used for DISH or UPL. In recent years, CMS has begun phasing out the use of DSRIP authority and has encouraged states to sustain their DSRIP activities through directed payments in managed care, which I'll discuss next. So directed payments are a new policy option that CMS created in 2016 to allow states to direct managed care payments to specific providers. In general, there are 3 main types of directed payments. First, minimum or maximum fee schedules require managed care plans to pay a specific rate for certain services. For example, many states use this authority to require managed care plans to pay providers no less than the state's fee-for-service payment rate. The second category are uniform rate increases, which increase payment rates by a certain percentage or dollar amount. These payments are most similar to supplemental payments in fee-for-service, and they account for the vast majority of directed payment spending. The third category is value-based payments. These can include requiring health plans to participate in a new payment model, such as shared savings for accountable care organizations, or they can include pay-for-performance incentive payments, similar to DSRIP. In recent years, spending on directed payments has grown substantially, from about $25 billion in 2020 to more than $69 billion in 2023, according to MacPac's review of available data. Unlike other types of Medicaid payments to hospitals, there's currently no upper limit on permissible directed payment spending. However, CMS has recently proposed establishing an upper limit based on hospitals' average commercial rate, which is much higher than the Medicare limit that is used in fee-for-service. So this figure illustrates the wide variation that we see in overall payment rates and the use of different types of Medicaid payments to hospitals. The data for this figure come from DISH audits submitted in 2018 for hospitals that received DISH payments. So first we see a wide variation in total payment rates. For example, State A on the left paid DSH hospitals only 70% of their cost of care for Medicaid patients, whereas State E on the right paid DSH hospitals 110% of their cost of care. Second, looking at states B, C, and D, we see wide variation in the types of payments that states make, even if their overall payment rates are just about the same. State B primarily makes large base payment rates to hospitals and doesn't make very large supplemental payments. In contrast, State C makes very large non-DSH supplemental payments, such as UPL payments. And State D primarily makes large DSH payments. When looking at this figure, it's important to keep in mind the limitations of available data. First, this figure only includes information for DSH hospitals in each state and does not include non-DSH hospitals. Second, there's been an increased use in directed payments since 2018, which is not reflected in this figure and may affect total payments to hospitals in these states. Finally, the figure doesn't account for provider contributions to the non-federal share, which I'll talk about next, and which affect the net payments that providers receive. So now let's review how Medicaid hospital payments are financed. Similar to other Medicaid payments, Medicaid hospital payments are jointly financed by states and the federal government, and the share of funding paid for by the federal government is determined by the Federal Matching Assistance Percentage, or FMAP. States can use a variety of methods to finance the non-federal share, including state general revenue, provider taxes, and funds from local governments, including public hospitals. In general, supplemental payments are often financed by providers, and they typically come about because of state challenges with increasing base payment rates using state general funds due to limited state revenue. Although many providers we have interviewed would generally prefer increases to base payment rates instead of supplemental payments, providers also want to be paid back the amount that they contribute to the non-federal share. And so many states use supplemental payments rather than base payment rate increases because it is easier to target supplemental payments to particular providers. This figure shows the share of non-federal funds for Medicaid payments from different sources in 2018 and illustrates the fact that DSH and non-DSH supplemental payments are more likely to be funded by provider taxes and funds from local governments than other types of Medicaid payments. Most states tax hospitals to help finance Medicaid payments, which is permissible as long as the tax is broad-based, uniform, and does not hold providers harmless through a direct or indirect guarantee that they will be repaid the amount that they contribute. There are some exceptions in the Medicaid statute and regulations that allow broad-based and uniform requirements to be waived if certain conditions are met. Also, as long as the tax is less than 6% of a provider's net patient revenue, more than 75% of providers can receive more than 75% of their tax costs back without triggering the hold harmless rule. This 6% limit is often referred to as the safe harbor threshold. There are two types of funds from local governments that can be used to finance Medicaid payments. Intergovernmental transfers, or IGTs, are transfers of funds from public hospitals or another local government entity to the state. For context, about 20% of U.S. hospitals are publicly owned, and many of these providers serve a high share of Medicaid and low-income patients. If a public hospital provides IGT funding to finance Medicaid payments, then other providers cannot donate money or services to that provider in order to free up government funds to finance more IGT payments. Also, it's important to note that some local government entities impose their own local provider taxes to finance IGTs. In this circumstance, the local provider taxes also need to follow local provider tax rules that I discussed earlier. Another type of funding from local governments are certified public expenditures, or CPEs, which do not require public hospitals to transfer funds. Instead, public hospitals document their costs according to federal standards in order to receive federal matching funds for Medicaid services. At MacPac, we have found that financing methods appear to affect how hospital supplemental payments are targeted. In general, payments that are funded by provider taxes are often distributed broadly to all providers that pay the tax, whereas IGT-funded payments are often targeted to public hospitals that provide the IGTs. From the hospital's perspective, providing financing of the non-federal share reduces the net payments that a provider receives. For example, in 2011, we estimated that provider taxes and IGTs reduced total Medicaid payments to DSH hospitals by about 11%. On the other hand, from the federal government's perspective, provider financing increases the effective FMAP paid by the federal government. For example, in 2018, we estimated that the use of provider financing methods increased the federal share of Medicaid spending by about 5%, from 63% to 68%. This figure shows more detail about how provider financing affected the payments for DSH hospitals in 2011. Although gross payments reported were greater than hospitals' costs of care for Medicaid patients, the net payments that providers received were below hospital costs. This figure shows how provider finance payments affect the federal share of Medicaid spending. In this hypothetical scenario, the federal government makes a $100 payment that is matched at a 60% FMAP, meaning the state puts up $40 and the federal government puts up $60. However, if the provider finances a portion of the payment with an $8 provider tax, their net payment is $92 and the effective FMAP to the provider is 65%. About 5 percentage points higher. So this concludes our presentation for today. To learn more about this topic, MacPac has a number of resources available on its website. In particular, our issue brief, titled Base and Supplemental Payments to Hospitals, is updated annually to include information on all types of Medicaid payments to hospitals. The issue brief concludes with links to many additional resources, including MacPac's annual reports on DSH funding and other reports to Congress with recommendations for changes to hospital payment policies. Our website also includes compendia of state payment policies, analyses of fee-for-service payment rates, findings from a variety of interview projects about the factors that affect Medicaid hospital payment policies, and information on the effects of new value-based payment models. Thank you.